Hi, everyone. Welcome to this really exciting session that we are having here on a Tuesday afternoon, really focusing on overdose prevention, trends, and response during the COVID-19 pandemic related to people who use drugs, and really just meaningfully recognizing that there are huge crises and overdose epidemics and epidemics within epidemics in this really challenging time. It is a pleasure to be here with some real greats in the field who are working to address this and find meaningful ways to support programs and support data collection and data sharing for overdose response across the country at multiple levels. So we're really going to offer up space today to get sort of a national overview of recent numbers that have come out from the CDC side of things around overdose mortality, and excited to kick off with that. And we're going to jump into, after that, more state and jurisdictional level perspectives around overdose response efforts and data collection and really community programming. And we are also going to really round out with some really great perspectives around overdose response efforts from the field itself, from people who are working directly with people and have been doing so for a really, really long time. This is, for those of us who work within the harm reduction space and the drug user health space, and well, I'll be honest, this last year has been a year for everyone. And has been felt really, really acutely among people who, communities of folks who use drugs and communities of folks who support people who use drugs. And so really excited to bring this conversation here for you all today. Just so you all know, let's see, some housekeeping things. You are able to ask questions. There's both a chat function in GoToWebinar as well as a question function in GoToWebinar. Unfortunately, attendees are unable to use their voice. We were just saying how sad that is. So feel free to, use those very liberally, and we will do our best to respond to questions and flag them for speakers as we go through all this. So without further ado, oh, and also this is being recorded and will be made available, on our website over here at NASDAQ, and perhaps we'll be able to send out that link to the larger registration list for those who are unable to attend at the last minute. But this is a really exciting, well, exciting is not the right word, timely conversation, and so I appreciate you all being here. So just very quickly, oh, I should back up. So my name is Laura Pegram. I'm the Associate Director of Drug User Health over here at NASDAQ. Just very quickly, we are, NASDAQ is a national membership-based organization who primarily works with state health departments and jurisdictional health departments, their HIV and viral hepatitis programs. For a lot of reasons, we, that is for a lot of reasons, drug user health efforts, syringe access, harm reduction efforts are often couched, and support for them are often couched in infectious disease, HIV and hepatitis health departments. And so that is a big part of the reason that we work very closely with programs also on the ground, as well as health departments trying to meaningfully support programs. So excited to be collaborating with the CDC COVID response team to bring you all this webinar. So without further ado, we'll go and just give a broad sort of overview of our speakers, right? So welcome Lauren Rawson on behalf of Farida Ahmed, who unfortunately was unable to join us today at the very last minute for a family reason. Well, from the National Center of Health Statistics, really going over more recent data and trends. Dana Quisenberry from Kentucky, our Kentucky Injury Prevention and Research Center, who I've had the pleasure of talking to several times, it feels like, in the last month, which has been great. Alice Bell, who's from Prevention Point, Pittsburgh, a long-time harm reduction and overdose response great, and pleasure to see faces, all these faces. And Kendra Viner from the Philadelphia Department of Public Health, who is also been a long-time supporter and advocate and doing some really creative, innovative work out there. So I'm going to go ahead and pass it off to Lauren to take us away from here.
Great, thank you. I can't see whether the slides are being shown.
Okay.
So I just want to make sure I'm in the right spot.
You caught it.
Okay, there we go.
To be.
Hi, everyone. So thank you. I am presenting on behalf of Farida Ahmad, and I've worked very closely with her over the past several years on developing our provisional drug overdose death data and the various releases. Next slide, please. So first, to give a high-level overview of the vital statistics mortality data, the National Vital Statistics System is the mechanism by which the National Center for Health Statistics collects and disseminates the nation's official vital statistics on births, deaths, and fetal deaths. The data are provided through contracts between NCHS and the 57 vital registration jurisdictions. And NVSS mortality data are based on information from all of the death certificates filed in the states, DC, and the territories. We have a variety of different data releases, including our final data files, which are released annually, and a series of provisional data sets that have only grown since the beginning of the pandemic. Next slide, please. So to orient you to our provisional data releases, all of these are under the heading of our Vital Statistics Rapid Release Program. And under that umbrella, we have a series of different provisional data sources, including our quarterly provisional estimates of mortality, Vital Statistics Rapid Release Reports, which cover different methodological issues related to the provisional data, along with some subject-specific reports on things like drug overdose and suicide. And then we have a set of surveillance activities, which include our provisional data on COVID-19, our monthly drug overdose death counts, and influenza surveillance as well. Next slide, please. So our monthly provisional drug overdose death counts are based on provisional death certificate data from the 50 states, New York City, and DC. They're updated on a monthly basis, and we release estimates with a 6-month lag. And I'll go over a little bit more about what that looks like in a bit. Typically, we're releasing data on the second Wednesday of the month. So our last update was on December 16th, and it covered data for the 12-month ending period ending in May of 2020. And our next update is scheduled for tomorrow, and that will cover the 12-month ending period ending in June 2020. Next slide, please. So this is a picture of the information that's available on these provisional data visualization pages. So first we have drug overdose death counts and related trends over time. We have a map presenting the percent change year over year in the number of drug overdose deaths, showing all of the states and reporting jurisdictions. And then we have another page that presents trends in the counts of drug overdose deaths that involve specific drugs or drug classes, and I'll go over each of these in a little bit more detail. Next slide, please. So as I mentioned, we're presenting 12-month ending death counts, so that's sort of a rolling annual count of deaths with a 6-month reporting lag, and we show both reported numbers of deaths and predicted numbers of deaths. We have data on drug overdose deaths overall for the US and all states. And then we show data by specific drugs or drug classes for the US overall and select states that meet our data quality criteria. Next slide, please. So because it's a little bit of a mouthful to say 12-month ending period with a 6-month lag, here's a visual schema of what that looks like. So we present sort of rolling annual estimates covering each 12-month period. And then we have 6 months between the end of the period and when we're analyzing the data and then publishing it. And this is because of the data reporting lag. So we want to allow enough time to go by that we're confident that the data are sufficiently complete to release. Next slide, please. So the reported counts are the actual number of deaths that we've received death certificates for as of the date of analysis. And we know that these are underestimated relative to the final counts that will eventually be in our data files. And so it takes a while for death certificates to be completed and filed and transmitted and coded and processed. And so there's this lag between when the death occurred and when the death are reported to us. So drug overdose death records in particular are often submitted initially with the cause of death, with the manner of death pending investigation, and then those records are eventually updated to reflect more detail. And this percent pending varies by reporting jurisdiction, by year, by month of death, by a lot of other factors. And so we developed an approach to generate predicted counts of drug overdose deaths. Sorry, if you could go back just a bit, there you go. Which are adjusted for these reporting delays. And we use that percent pending variable to make that adjustment to basically get a more accurate count that accounts for some of that underreporting that's present in the provisional data. Next slide, please. So to show you what that looks like, the dots show the predicted numbers of deaths. And so looking at the 12-month ending period, ending in May of 2020, we have 81,230 deaths that are predicted to have occurred in the US over that 12-month ending period, compared with a reported count of 79,251 deaths. And this is in our most recent provisional data release that's up live on the web now. Next slide, please. So we can also look at the year-over-year change in the number of drug overdose deaths by state and for the US overall. And we can see that comparing the 12-month ending period ending in May of 2019 to that ending in May of 2020, the number of drug overdose deaths for the US is up 18%. And there's a lot of variability across the different jurisdictions as well. Next slide, please. And even with a certain amount of underreporting in the reported death counts, the change year over year in the reported numbers of drug overdose deaths is still up by 16.9% year over year. Next slide, please. And here you can see the trends for the US in the number of drug overdose deaths by specific drug or drug classes. With the black line being opioids and the brown line being synthetic opioids, excluding methadone. And we present both the predicted and reported counts for these outcomes as well. Next slide, please. So just some considerations when you're either using the data or trying to keep tabs on trends, recent trends. The data are provisional, and so we know that they may underestimate the true number of deaths that have occurred. And we would caution people to not make assumptions about what may be driving those recent trends because of these data quality and reporting lags. Additionally, we suppress counts for states where the number of deaths is less than 10. And we only showed the drug-specific data for states that meet certain data quality criteria for the most recent 12-month ending periods. And so those criteria are related to the completeness of data. So the states have to have submitted more than 90% of death records overall. They have to have had less than 1% of the records pending investigation. And then they have had to have had at least 90% of drug overdose deaths with a specific drug mentioned on the record. And so we impose these restrictions to sort of mitigate the impact of reporting differences, underreporting, and data quality changes on the resulting trends. And so, for example, if a state has improved their specificity of information on the death record, so now we have a lot more records with specific drug information, then that can cause increases in the number of deaths due to that specific drug. And so we want users to sort of understand the limitations of these provisional data and just be cautious about interpreting any related trends. Next slide, please. So here are some links available to existing resources that may be of interest. We have our drug overdose provisional data page. CDC Wonder is a great source of information for our final mortality data to look at historical trends through 2019. And then we have a variety of ad hoc data releases, including ones related to provisional drug overdose death data by county and select demographic characteristics. And then we have ongoing quarterly provisional estimates of mortality that are released every quarter, and they include overall death rates and death rates for select causes. Provisional drug overdose death rates are lagged by 9 months to ensure that they're sufficiently complete, and so the most recent release includes data through the third quarter of 2020. And we plan to publish the next update this week. Next slide, please. So feel free to reach out to Farida if you have any questions. I'm sure she'd be happy to respond and have ongoing discussion. Thanks.
That's perfect. Thank you so much, Lauren. And again, thank you for stepping in on such late notice. Couldn't even tell. Great. So we're going to go ahead and move forward and pass it over to Dana, who is from the lovely state of Kentucky.
Yes, thank you very much. I appreciate being invited to participate today. Our presentation is going to focus on our surveillance efforts of overdose trends in Kentucky during the COVID-19 pandemic response. We are CDC funded under the Overdose Data to Action, and I am the PI over the surveillance piece. My colleague, Dr. Bunn, is the PI over the prevention piece. But as intended by the funding, we work very closely together to make sure that the data informs our prevention activities, both internally as well as across the state. Next slide, please. I think this conversation starts with this very, very busy slide of what our pandemic response looked like in Kentucky. We were declared an emergency very early in the epidemic, March 6th to be exact, which led to a number of safe at home measures that passed, including the closures of schools, restaurants, bars, non-essential retail, also limiting essential retail, the number of individuals allowed in it. In April, we continued on our closures and limiting store capacities. We did start our efforts to reduce the COVID burden in our incarcerated individuals. And so we had a program to commute sentences. We also began very early planning for our Healthy at Work, which would be the restart of our business plan. In May is when that plan began to be implemented. It was a staged implementation with manufacturing, construction, retail, office-based businesses beginning about the middle of the month, and toward the end of the month, restaurants and bars were allowed to have greater capacity and set, interestingly enough, set the limit to in-person gatherings to 10 individuals or less. June, we continued with our reopening plans by opening more businesses, increased capacity for businesses that were open, and a relaxed attendance restrictions. As we moved throughout the summer, we had our first face covering mandate in July. And we also, due to increases in COVID, saw a pullback of guidance on social gatherings and restaurants and bar activities. We had hoped to return our students to in-person education in August, but that was again delayed. There was additional rounds of commuted sentences, extended travel advisories, and such on through August to September. And the reason I wanted to give you this timeline, because we have observed and will continue to test and examine a really interesting observation. If you'll go to the next slide, please. When we look at mortality rates, this actually goes January 2017 through September 2020. And we, as a state, have struggled, as Lauren had described, with the CDC, the NCHS coding mechanisms, that it takes a while for things to get through. And in 2012, we were one of those states that had very poor drug specificity on our death certificates. So there's been tremendous amount of work that has been done by our state medical examiner and our 120 elected coroners to improve that reporting. So I'm going to start with this trend in 2017 because the year 2017 was our worst on record. And as you can see, we had a high month in February of 17 of 158 deaths in that month. We brought that down in 2018 2019, it started to creep back up towards the end of the year. We actually ended 2019 at a high. So pre-pandemic, January, February, we were higher than anticipated and higher, obviously, than the year before for those same months. Pandemic hit in March. As business closures and stay-at-home went into place, we saw increases in overdoses. May was a record month for us. We start seeing reopening of businesses in mid to late May. We see that drug overdose count come down. The last 3 months there are grayed out because we do know that the data is less complete for those years. So what is reported here is death certificates that are complete and NCHS coded. And we also do a little bit of work with natural language processing to determine cases that would be, hopefully will be determined to be an overdose later when they process through coding. So this pattern of overdose fatalities seem to follow our stay-at-home and reopening plans. We will continue, as I said, to test that moving forward. If you'll go to the next slide, please. Looking at overdose morbidity, coming down a layer in that pyramid of substance use disorder, not everyone has a fatal event. We did recognize very early that the delay in our administrative claims data would not make it a useful tool to examine during the pandemic. So we relied on emergency medical runs, ambulance runs from the Kentucky Board of Emergency Medical Services, and as well as our syndromic surveillance feed through the NSP Essence. If you'll go to the next page, please. I think this is a common experience for most of us in the country. This is our syndromic feed for Kentucky starting in January of 2019, and you can see come March, this is for all overdosing, or not just overdose encounters, this is all ED encounters. So when the pandemic hit, we saw a near 50% drop in utilization of the emergency department. And of course, that has come back up as we have planned our pandemic response and people have gotten used to our new reality. If you'll go to the next slide, please. This represents 2018, 2019, and 2020 of our opioid overdoses in Kentucky, identified in syndromic surveillance. And as you can see, even with the mortality data, like with the mortality data, our morbidity data ended up on a high in 2019. So we started at a high point coming into 2020. And we saw the same thing in our morbidity data from syndromic surveillance that we saw in our drug overdose fatalities. We had a bump in May and June, starting to come down. And this made us feel like the syndromic surveillance, as well as our efforts to include natural language processing, that we felt with the data sets matching pretty quick, closely visually. We will continue to test that statistically, but we felt pretty good that we were observing similar trends in both data sets. If you'll go to the next slide, please. This is our EMS opioid overdose runs aggregated by week. We dropped in the National Emergency Declaration. It was just on the heels of our own declaration in early March. And as you can see, we see the hump in May. And it seems to be declining now that we have businesses reopening. And as a caveat, we get our EMS data weekly. If you'll notice, the end of December, our data seems to drop off. That's because our Board of Emergency Medical Services took a hiatus along with the rest of us. So we have now, we'll start backfilling that data to be able to understand what's happened in the last few weeks of December. But all in all, we seem to be declining in our EMS runs with overdose, but we are not seeing a return to pre-pandemic levels. If you'll go to the next slide, please. Another phenomenon that we noticed in EMS data is that number of EMS runs where the patient refused to be transported post revival in the field has increased. I know this has been noted in many other jurisdictions as a problem much earlier than what it was in Kentucky. As you can see, our refusal rate was pretty low pre-pandemic. Post-pandemic, we have definitely increased the number of individuals who refuse transport after reversal. And that's a trend we're going to continue to monitor because it has not returned to the pre-pandemic baseline. If you'll go to the next slide, please. So all this data is great, but how do we make this data actionable? So we've been monitoring with our KSP partners changes in the drug supply, and that has been somewhat of an explanation for what we've seen, because we've seen a transition now to more fentanyl analogs, even though we were already suffering from increases in fentanyl access prior to the pandemic. It really has hit us hard post-pandemic. We've also had some anecdotal conversations with our syringe exchange programs that have seen some changes in drug usage patterns due to the data, or not to the data quality, the drug quality. So people are injecting more often, and there's much more variability in the quality of the drugs. And as time goes on, we will try to assess whether that has the influence of seeing the poor quality may have been in May, if that wasn't the explanation for that large bump in May. Time will tell, and more work is definitely needed. We have a core group which is funded by SAMHSA. That's the Kentucky Opioid Response. I think a lot of states received money from SAMHSA to be able to do that. We've now started monthly briefings with the core team, and that's allowed us to do things like help support telehealth delivery of treatment services, as well as changing in our naloxone distribution, both internally and statewide. We have a mobile harm reduction unit, and of course, with pandemic response, it was shut down initially. So we did some alterations and did some mail outs of naloxone. They were very nimble in their response. And then once COVID testing began, we partnered with COVID-19 testing in a number of areas to also offer naloxone distribution in those locations at the same time. So it has been an excellent partnership, and we've continued to be nimble and do what the data has shown us that we need to do for the prevention of drug overdose. If you'll go to the next slide. That's all that I have, and we'll do questions later. Thank you.
Great, thank you so much, Dana. Just really such staggering numbers. It's hard to sit there and watch. I don't know if you can see it on my face, but I just it's hard to feel and hard to navigate. And so I was thinking that this might be a good time to kind of switch over and get more of a perspective from folks on the ground and really hear from the lovely Alice Bell, who is over at Prevention Point Pittsburgh. And Alice, I don't know if you just want to take it off from here and give us some reflections on observations from your team, from your long history in overdose prevention. Be much appreciated. I think you're muted. Hold on.
Now I'm not. Yeah, so I work for Prevention Point Pittsburgh, which has been, I'm the Overdose Prevention Project Director for many years. We've been providing syringe exchange services since 1995 in Pittsburgh, and we've been distributing naloxone since 2005. We have one fixed indoor service location and 4 mobile sites that operate from a van in various different communities in Pittsburgh. And so in addition to supplying sterile injection supplies, safer smoking supplies, and naloxone, we have a wound care clinic, case management services to help connect people with housing, employment, treatment, you name it. And we've been distributing fentanyl test strips for a number of years as well. Unfortunately, after more than 25 years of successfully providing harm reduction services in Pennsylvania, Pennsylvania law still makes it illegal to for people to access sterile injection equipment in the state. Pittsburgh and Philadelphia programs operate under a local ordinance, and we've been able to do that without challenge for 25 years, but the rest of the state has no legal authorization to operate, which is a pretty sad state of affairs in 2021, given what we know about public health, and in a year when the governor declared syringe service programs to be an essential service that needed to remain open during the COVID lockdown. We have at Prevention Point Pittsburgh, we've managed to keep all of our sites fully operational throughout the COVID pandemic, but staff and the people we provide services to are under tremendous stress, as is everyone in the country, I think. In March, we moved pretty quickly to establish COVID protection protocols that we've continued throughout the year without changes. We have not adjusted it up or down. It's stayed the same. And we've been successful in nobody on our full-time staff has had COVID. And we set up separate teams so that if somebody did become infected, we would not have to all quarantine and close down our services. And we've changed the setup of our site to limit contact, maintain physical distance, required masking of people, which has taken a toll on all of us, as there's been no space for private conversations. There's no ability to give a hug or share food or the things that we sorely miss being able to do at the sites. We also have historically been heavily dependent on volunteers. We've been a mainly volunteer program for 25 years. And now we really restricted the use of volunteers to prevent COVID exposure, and that's been an additional increase on our staff. We've taken on additional services as there have been gaps in the services that people who use our program need. People have greater needs and limited access to other services. So we've been doing emergency food distribution. We've given out thousands and thousands of masks and bottles of hand sanitizer, which has been hugely appreciated. And we've also implemented some planned expansions during 2020, including establishing, in collaboration with Next Distro, we've established a statewide naloxone mailing service, which has been useful in the time of COVID when people have been more restricted in where they could go. And we also started a couple of months ago a mobile medical van to provide wound care and buprenorphine prescribing at all of our mobile sites. I mean, the medical van is gradually scaling up. We're up to 2 out of 5 sites now, but within the next couple of months, we'll have it at all of our sites. Both of these programs got really delayed in their launch because of COVID, but they're now operational. We've mailed naloxone to over 800 people around the state. That program's set up to reach people outside of Philadelphia and Pittsburgh and other parts of the state that don't have access to naloxone as easily. Prevention Point in Pittsburgh and in Allegheny County and southwestern Pennsylvania, we've given out over 8,000 doses of naloxone in 2020, which has been an expansion from the year before. We've seen all of our services have expanded during the pandemic. I mean, we're seeing more people at all our sites. We are seeing people who report that they've been injecting for years, but have never used our syringe service program before. And in asking them kind of what's been going on, they've said, well, I've always worked, I had money, I bought syringes at a pharmacy, and now I lost my job. So the medical van has been, just taken off gangbusters. We've seen 50 people already. And we've had, I know we had one day at one site where we saw 25 people in one day. So we think that this is really demonstrating tremendous unmet need for to offer, you know, this kind of life-saving service of buprenorphine in a low barrier delivery method. We've continued to expand our community health advocate program, where we have people who use our services, who are distributing naloxone and other supplies in neighborhoods that we don't reach through our existing sites. And but I would just say that you know, looking at the data that other people have presented, I mean, we've also seen an increase in overdoses and overdose deaths starting in mid-2019. We've been seeing a steady increase quarter by quarter in deaths and in non-fatal overdoses as well. Our data, Prevention Point's data on overdose reversals, which are, you know, almost 99% non-fatal, almost none of them are fatal. We've seen from mid-2019 increase quarter by quarter. So I think that while we've managed to maintain and increase the services we're providing, it continues to be really a small drop in the bucket of what's needed. I think that overdose deaths locally and nationally that have, you know, where we're seeing these increases in 2020, I think that COVID has just exacerbated what we've already seen. All the reason that we've had astronomical numbers of overdose deaths in recent years have just been made worse under COVID. COVID didn't cause this in and of itself. What we're seeing on a daily basis is that people are in desperate need of all the things that everyone needs: food, housing, healthcare, education, employment, care, and respect. And I think, you know, when we look at what's happening now, why we're seeing increases in overdose deaths, fundamentally, it's not, you know, finding the hot spot and trying to address, you know, an immediate targeted problem. I think that we really can't hope to adequately address the problem of overdose without ending the criminalization of drug use. We talk a lot about stigma as an obstacle to, you know, getting people the kind of services they need. But I keep coming back to the question of how do you reduce stigma for something that's a crime? You know, we want people to not treat people who use in a stigmatizing way, but we're continuing to make them criminals. So that's kind of a bit of a dilemma there. So I think that, you know, to really make changes, we need to address underlying social problems of poverty, structural racism, inadequate access to healthcare and education, income inequality, all of those, you know, really big picture issues.
Yeah, that's real. Yeah, Alice, thank you so much. And yeah, just speaking so eloquently about the need to really look at these larger picture issues. I mean, what COVID has brought up for so much of the country right now has been evident and apparent for communities of folks who use drugs for a really, really long time. And there is, I try to be an optimist sometimes, but I do think there is an opportunity moment to really use this moment for, you know, to really make that, paint that picture as well as we can using both data and lived experience. And so whew, I need a breath. Okay, Kendra, I think we're going to turn it back over to you to move to the other side of the state up there in Pennsylvania, and yeah, tell us a bit about what you all have been seeing. And
Sure, and I don't have any good news to add to the story, unfortunately, as I'm sure you expect. But I'm really happy to be here. Thank you so much for the opportunity to speak today. I am director of the Division of Substance Use Prevention and Harm Reduction at the Philadelphia Department of Public Health. So as mentioned, I'm operating on the other side of the state from Alice. Next slide. So sorry. Right, thank you. So beginning in about 2014, we started to see an increase in drug-related fatalities in Philadelphia, largely relating to the influx of fentanyl into the heroin supply, as really is being seen across the country. The peak of the crisis was in 2017, and the number of fatalities per year that we're seeing in Philadelphia remained stable, really around between 11 and 1,200 a year, which is an enormous number of people since then. So that now we have about 3 times as many deaths from overdose as we do from homicide. Next slide. I'm just going to jump right into how the COVID-19 stay-at-home order in particular has influenced what we're seeing in Philadelphia. Next slide. So this shows drug-related overdose fatalities broken down by race and ethnicity. The blue bar there is non-Hispanic whites. The green bar is non-Hispanic blacks, and the Hispanic, or the yellow line there is Hispanics. And we did not see through the first half of 2020 a huge increase in the total number of overdose fatalities, but what we did see was a shift in the proportion in the demographics of who's dying. And it's really dramatic here. You see this complete switch from majority non-Hispanic white prior to the COVID stay-at-home order, which is indicated there by the red line, to majority non-Hispanic black. Next slide. And this doesn't indicate the drug combinations, but basically that, again, the green line there is non-Hispanic black individuals who have died. Most of those deaths, the majority, 80 to 90%, have been driven by a combination of fentanyl and cocaine in the toxicology. Next slide. So this was an interesting observation to us. We found that most of majority of the black non-Hispanic individuals who fatally overdosed were unemployed at the time of death. You can see that green line again, there was an increase between Q1 and Q2 in the proportion of individuals who are unemployed. So we don't know why we've seen this switch, but our guess is that this is probably playing into it, whether it's because there's increased desperation from job loss and initiation of drug use, or whether it's turning to drug supplies that are less well known or more likely to be tainted. We don't know. Those are questions we want to dive into, but I think this is a really striking finding I wanted to share. Next slide. And this is Naloxone Administrations by EMS. So this is really our proxy for non-fatal overdoses. And you can see the same result here with the majority of individuals receiving naloxone out in the community being non-Hispanic black after that stay-at-home order. Next slide. So I'm just going to jump right into some of the things that we're doing to try to respond to this. So the first is, and this is something we're always working on, but we definitely have an additional fire lit under us now, and that's to really work on increasing both the availability and the accessibility of naloxone. So we distribute over 50,000 doses a year in Philadelphia to first responders, criminal justice organizations, healthcare providers, and community-based organizations. We have a policy in place that requires all pharmacies to carry naloxone. And we did a survey in the fall of 2020 and found that 98% of them are in fact stocking naloxone. So that's a good thing. We've also really worked hard to promote online ordering of naloxone through NextDistra, which I think Alice mentioned is also used in Pittsburgh and in other parts of Pennsylvania. And we have seen, especially since the COVID stay-at-home order, a huge increase in people who are ordering naloxone through this mechanism. Next slide, please. We're also working hard to increase accessibility of our harm reduction trainings. So we've trained thousands of people to date. We have ongoing virtual trainings, and then we're also doing in-person outdoor pop-up events in neighborhoods that may not be aware of our website or the fact that there are virtual trainings, and just sort of are a little more off the grid when it comes to accessing city services. And those have been very successful as well. Not all of our trainings, but a lot of our trainings are done in Spanish as well, especially in neighborhoods where there are high proportions of Spanish speakers. And the topics we're constantly sort of adjusting to stay kind of up to date with what the trends are in what's being found in street drugs, the rise in fentanyl within the stimulant drug supply, et cetera. So next slide, please. We are shortly going to launch a large-scale fentanyl education campaign, and this is really based on data that fentanyl is in everything. I mean, we are finding it in stimulants, we're finding it in hallucinogens, we're finding it in synthetic cannabinoids, and we really are at a point where we need to get out this education that all drugs really have a risk of carrying fentanyl within them, and that people should consider using fentanyl test strips to test their drugs prior to use. And so we'll be distributing fentanyl test strips in hard-hit neighborhoods, and along with these cards indicating that fentanyl is in, as you see, cocaine, crack, pills, meth, PCP, everything. Next slide, please. We're also working with the community to prevent overdoses in special populations. So we distributed just a couple weeks ago a one-pager to community-based organizations that we haven't traditionally interfaced that much with. So primarily those that are serving populations of color or in neighborhoods where, we just haven't done a whole lot of outreach. And the one pager provides, on the first page, provides some basic statistics. And then on the second page indicates that we'd really like to build partnerships. And so indicates what we can provide the organization in the form of trainings, naloxone, education materials, even staff who could help distribute those materials or naloxone, and then also ask for their help in providing their perspective on the crisis, information about what their community is currently doing to address the crisis, if anything, and then advice from them on how we as the health department can tailor messages and services to have the best chance of reaching the populations that they serve, understanding that we really are not the experts in that at all, and that that a lot of that messaging has to come from them. And we've we're really happy to get a lot of response already to this, mostly asking for trainings and naloxone, but it's a first point of engagement. So we're excited to move forward with that and start to really build some foundational partnerships. We're also working with Vital Strategies and have issued 5 mini grants, again, to many of the same organizations, primarily that serve Black and Hispanic populations, to help them build harm reduction capacity within their organization. Next slide. Sorry, next slide. The other thing that we're doing is really working to continue to think of new ways to link individuals to treatment from a wide variety of settings. So the Philadelphia emergency departments, all of them, have been working hard to build protocols to help hand off people who come in for a drug-related reason to drug treatment if they're ready for that. But we're also trying to think of additional ways that we can do this from the community directly. So one way is through the fire department, EMS, their AR2 unit, and that's the red van that you see there on the right. And this is a unit that goes out along with the ambulance to respond to individuals who had an overdose and refused treatment to a hospital. And it engages them directly with case managers to assess additional needs that they might have. And it's not just drug treatment. It may, whether it's harm reduction needs, whether it's housing, whether it's help with insurance, And that has been extremely successful. I mean, it's gotten to the point now where they're, well, really sort of pre-COVID. COVID sort of put a giant halt on this. But before COVID, it got to the point where people were really waving down this van, and they were getting a lot of sort of direct connections just by people who were interested, who knew that they could help them link to services. And so, it's wonderful. It's wonderful to sort of build that trust within the community. We're also doing work with police-assisted diversion. We have a program, a case management program called LEAP, which is engaging individuals who are currently incarcerated and receiving treatment behind the walls to provide them with case management and then linkage to treatment after they're released from prison. Again, prior to COVID, that was going very well. It's been a little touch and go since then. We're also working with individuals who were reported to the health department with hepatitis C, or the mothers of infants who are reported with neonatal abstinence syndrome, and engaging those individuals to see again whether there are services that they need that we can help them with and in providing referrals. And then we're working with Prevention Point Philadelphia to do a lot of the same thing. Next slide. So I hate to end on this, but it looks like, and again, this is preliminary, but it looks like 2020, we're going to end up with a higher number of fatalities than we did at the peak of the crisis in 2017. We also have seen, and you can see that with the blue line there, a dramatic increase in homicides in Philadelphia, a lot of which are drug related. And so there is clearly a lot of work that we need to do. I mean, we're in a situation now where we really have to double down on our efforts and think of new ways to reach these vulnerable populations. And I know that's true for everyone on this panel, so preaching to the choir. Thank you.
Yeah, thank you so much, Kendra, and thank you to all of the panelists. Yeah, this is a tough one. This is a tough conversation needing to be had, and a really, really important one. So I appreciate everyone's work on this. We do have some questions in the chat box, and as I'm kind of sorting through them, I kind of want to prompt this panel. My initial question is always this dichotomy, this tricky thing around data. My dog. Data being really can feel really depersonalized. The programs that we know work best with people who use drugs treat them like people, and I guess I'm curious if and sometimes data can take us away from the humans behind these numbers. And I guess I'm curious if any of you have thoughts about ways that you've been able to use data to humanize this overdose epidemic, and or if you have thoughts about how we as a public health community could be better about doing that.
I'll take first crack at that because we deal so much with state and community stakeholders that are working in the space on the ground, that it's a small comfort to know that the efforts that we put in place probably have kept it from being much worse than what it has been. But once again, that is a small comfort. Really paying a lot of attention to destigmatizing the issue. We still have stakeholders and community members that approach this issue not as person-centered. So, we continue to battle that issue as well. I recently did a very quick descriptive study on our commuted sentence population, and it was remarkable how well their reentry plans for that special population worked, but we still lost a few of them to overdose. And it becomes a very difficult conversation to have without minimizing their loss, just to promote how well the program did in fact work. And I think that's something we're getting better at as we continue to talk about the things that we're doing. That's one of the things we've realized in Kentucky. We don't talk often enough to the media and to the community and the public at large about what we are doing. So it's kind of like happening in a vacuum for them.
I think for me, it's combining data with personal stories as well. And, one way that I think we have helped to humanize the drug crises in Philadelphia is through our overdose fatality review process, and really talking about, 5 or 6 individuals every quarter and their life story, at least what we can glean of their life story from talking with next of kin and from looking at medical records and things like that. And, where the city sort of let them down, or what services weren't in place that may have, helped to prevent them from overdosing.
I think I'd echo what Kendra said, that I think that, using data and anecdotal stories, whether it's about, a person who overdosed or just, the kinds of things that you're hearing in the community. So, you can look at increases in overdose and say, people we see at the syringe exchange are saying things are crazy. I don't know what's in my dope. There's all kinds of things out there. I have no way of knowing what's in it. And we know that that's really what leads to overdoses is people have no way to know how strong it is or what it is specifically. And that's always been a problem with, that Canada is making some efforts to address with their safer supply efforts. I usually, when I do presentations, try to have graphs and data, and also develop a narrative, tell a story that's a piece of.
Lauren, any thoughts to add on that?
I think it's tough from the perspective of someone who works at a federal agency providing national level data to kind of juggle those two things. Yeah. Because when you're looking at the sheer number that we're looking at, over 80,000 in the most recent 12-month ending period, it's an overwhelming number, and it's really hard to kind of personalize that in any way other than to say this is a really large number in a lot of places that affects a lot of people. And to make a sufficient level of detail available in our data that can be used at a more local level to try and better understand kind of what's going on in local communities.
Yeah, I mean, at all the different levels, the data is the thing that we need, and we need to help justify some advocacy and to justify the resources and increased resources and allocations for people who use drugs. And also, you said it right, Lauren, right? Like, these are wildly overwhelming numbers, staggering numbers, and so, really double-edged there. That was an aggressive reference. We didn't need to end on that, but certainly a challenge both for programs and for different levels of community stakeholders. So we do have a couple of questions that I think that some of them we can kind of follow up with offline a little bit. Some questions about specifically thinking about any advice about data collection on vulnerable populations, folks who are unstably housed in particular, and some of those challenges, questions about health disparities among marginalized or minority groups, and sort of how you account for data collection and making sure that we highlight those as well. And I really recognize that we are basically out of time. So if there are any last thoughts from this panel, I will do my best as our team to get these questions routed to the right people in the right places. Go ahead.
If I may, one of the things that I am very concerned about in our surveillance efforts is being able to monitor what's going on in the LGBTQ community. I'm to say that, Tara, I may have left out a letter, I'm sorry. Because there's not a field for gender identification or sexual orientation in any of the administrative data fields, data sets. And I think we do not have a strong picture of what's happening in that community. And, you know, that story is similar in the area of those doing suicide prevention as well. You know, without some mechanism to identify them in the record, we can't do proper surveillance, but at the same time, identifying them in a record is problematic for stigma reasons and lots of other things. So yeah, I think it's going to be a challenge for us moving forward doing surveillance with that particularly vulnerable population.
Yeah, thank you, Dana.
I wanted to say just one quick thing that sort of pertains to the question that you asked, Laura, and I'm thinking about what Lauren was saying and being in that situation, you're doing his data. But I think that sometimes when you know, being in these kind of meetings and webinars, and when, you know, and people are asking the question, the big question, like, well, why do we think that so many people are using drugs? And I always just ask people, I'm like, how many people that you know are drinking more? And everybody kind of was like, oh gosh, you know, everybody. And I think that, you know, when you know, the getting away from like, this is this special population of people over here that we're looking at, that it's really, you know, an us issue, that these are, you know, these huge numbers show that this is just our population. This is just Americans, people, not drug users. It's us, not them.
I like that, Alice. I'm going to steal it.
Sorry for this dog. I don't know if we could have ended on a better note. At the end of the day, data is vitally important, and we're so grateful for all of our community stakeholders and who are able to use and leverage that data to really advocate for programs and support programs meaningfully. It's that time of day, and really just grateful for everyone on this webinar. Just can't appreciate you all enough. So we will have a recording of this available, and we will make the slides available in a PDF form on our website as well. So really appreciate all your work and hope that everyone has whatever kind of week they need to have moving forward this week. So good to see your faces, and feel free to reach out with any questions or follow up. Thanks so much, everyone.
Thank you, Laura.